How many of you all feel like this is you in your IT department? We're not quite there yet. I'm not allowed to stab anybody, but I keep asking. I really want the keyboard that shocks you when you don't do it correctly, but they won't let me have that either. Dr. Velasco, if we could put that in the budget for next year, that'd be great. I appreciate that a lot. So you've noticed that we've told you a couple of different things. Sepsis can be a very cookbook kind of medicine because we have very well-established things. So your electronic health record should be able to help you with this. It should be leading you down the correct path. All right, so we're going to talk about some tools in the electronic health record. I'm going to try really hard to keep it vendor neutral. We've already talked some about your specific order sets. Those need to make sure we're going to do a little bit more on those. We also want to talk about our CDS, or our clinical decision support. How many of you all think that clinical decision support is just a BPA? If you do, we need to talk. And we're going to. Ha, that's why I'm here. Care coordination tools, and my favorite, predictive analytics. All right, we already talked about the fact they need to be precise. They also need to be tailored, because the way that the order sets work in the emergency department are not necessarily the same way that they work in the ICU or on the floor. Those physicians have different workflows that they're trying to fit within, so those order sets need to be tailored for how they work. Nurses have a different scope of practice, so their order sets have to meet a different level of scrutiny, and they have to be able, for the nurse to be able to do this and protect their license at the same time, because I don't know about you all, I kind of like paying my mortgage, and my license helps me with that. So we want to make sure that we keep you within your scope of practice when we tailor your order sets. If you study anything in Texas about standing delegated orders or standing medical orders or protocols or any of the other stuff, your eye will twitch like mine does. And you'll know that you have to be very careful when you set up your nursing order sets that they are keeping them within their scope of practice and they are being appropriately vetted and signed on the back end. Clinical decision support. There are lots of chapters and lots of IT books about this. What clinical decision support really is, if you want to boil it down, it is help at the point where the clinician needs it. The electronic health record should never really be the thing, it should not wag the dog, right? It should be there to support what you are doing. I love the mention of the millennials. We are used to our devices giving us clues as to what we do next. We feel more secure when they tell us, turn right at the next light, right? But if you turn right at the next light and drive into a lake, it really didn't help you. So you want your clinical decision support to provide you that kind of support, but you also need to be able to look at it and make some decisions from it. Just remember that. We want to make sure that our clinical decision support embeds links. We want to give you the information at the time that you need it. I don't want to make you go out to some other site, log into another site to be able to read the algorithm I need you to read right now. So that little link needs to take you to the algorithm. And then you need another one that if I want to sit there and read the long article, we can give you that too. All of those can be supported by clinical decision support. Links to articles, links to pathways. Then we get to the best practice alerts. How many of you all like best practice alerts? How many of you all like getting those? I saw so many hands go up. What? Best practice alerts work best when they are actionable, meaning it takes you somewhere and it takes you to the correct place. Clinical decision support means that we are making the right thing the easy thing, and that we are leading you down the correct path. So if you get a best practice alert that says, hey, the stars have aligned and we think that your patient might be getting septic, it needs to take you to the place where you can do what you need to do. It needs to take you to your screen. It needs to take you to your orders. It needs to take you to your information. It needs to help you along the way. All of the EHRs have the capability to do this. You just have to work with your IT people, and then we can help you to design systems to help support the correct workflows. We want smart order sets. We don't want this really long set that you have to scroll through. We want to make it smart so that it tells you what you need to do and it lets you open things up and it keeps you where you need to go. We also want to have what we call smart tools. Anybody that has ever had to work with me knows that I hate notes, hate notes, hate notes, hate notes, because they're not discrete. Discrete data elements, think of it like a little mosaic tile. So that blood pressure is a little mosaic tile. And from that little mosaic tile, now I can take that and put it into a picture that the physician needs to see. And I can take that same mosaic tile and I can put it into a picture for the nurse to see. And I can take that same mosaic tile and I can put it in there for quality to see. But I had to have the tile in order to create the picture. And if you bury it in a note, we can't help you. I hate notes. We also want to remind you gently that you need to do something before you're allowed to do something else. But you need to be real careful with that one, because do I really want to stop you from being able to take care of your patient because you didn't fill out this little box? Most of the time the answer to that's no, and I'm with you on that. But we do, before you send them home or before you transfer them out, want to give you a good reminder. Hey, you forgot this. Go back and do it, or we're not going to give you your discharge instructions. Then people tend to go back and make sure that they're completing all of the steps. So you want to be real careful with those safety net lockout tools, that you're not preventing them from care, but that you are providing reminders and not letting them have that carrot until they go do what they're supposed to do. Care coordination tools. All of the different EHRs have different ways that different providers can see the same information. Sometimes providers want to see all the same information all the same way. The nurse wants to see it just as the physician sees it, just as the respiratory therapy sees it, just as pharmacy sees it. That's good, but most of those disciplines also want to have a way to look at it in the way that they want to look at it. The physician is looking at this set of information, and the nurse wants to see it as this set of information. And we can do that. We can also pull it all together for you. We want to have good navigation tools in your EHR. We want you to be able to find things. How many of y'all like going to 16 different screens to find 4 different pieces of information? Okay, Kirsten, I got that. We'll make sure and do that one for you. I got it. You really want to have all of it in one spot, especially for these things that are time sensitive. You don't want to have to go to 6 different screens to find my lactate, to find out if I got my fluids, to find out what this was. You want it all in one place. Work with your IT people and your vendors. We push our vendor. In fact, our poor technical support guy, he hates to see me coming because he knows that I'm going to beat him over the head with sepsis and foreign language. Those are my 2 things I love to beat him up about. But they work on it and they help us with that. And when you really work with your vendors, they become very supportive and they will help you and they will help you partner. But you have got to talk to them and you have got to push. Ours have been very responsive to us, and they continue to come up with new ways for us to do all this really cool stuff. But we have to work with them. Then, how many of y'all in here are your quality folks? How many quality folks do I have? You all have to do all this reporting and stuff. I bet you all love having to go all over the chart, don't you? Fun, isn't it? We've actually created within our record a way for all of these elements that we know that we're doing for our core measures, be it for sepsis or be it for heart failure or any of these others. We pull these together for our quality folks to be able to find in one spot. They have their dashboards, they have their metrics, they have their things in the places that they need to see them, and we also have this pulled together for our clinicians because some of us need to see it real time and some of us need to see it retrospectively, and we all need to be able to do a deep dive. So your electronic health record can do all of those different things if you work with the providers to make sure. What we did is we had all of our quality folks pull together and said, okay, here are your sepsis core measures, here's where we're going to document this, we're going to pull all this together for you and we're going to give you this little report. And they're happy. But they're only happy to a point because they say, well, it doesn't show me this. And we work with them every month to go back and see, okay, well, what can we tweak this to do? How do we pull this to do this? We're missing this point. How can we help do that? But you have to continue to work for them. All works out well. All right, predictive analytic tools. I love predictive analytics because I think the electronic health record should be helping you and not a data repository. The way that we do that is we have scoring systems and predictive analytics. There's also a next step for those of you taking notes for your program at home, are prescriptive analytics. So predictive analytics lets you know that there is something going on. There's a problem here. Prescriptive analytics tell you there's a problem, go do this now. So we're going to combine those 2 things to get us to our place that we want to be. These are some of the ones that we use for sepsis. SIRS, okay, we all know that you're going to use it for SIRS. Muse, which is the modified early warning score, that can be used for several different things. When we put in the modified early warning score at THR, within the first 6 months, we saw 66 patients that did not have a code blue because their Muse score had identified them early and we got them a rapid response team instead of a code blue team. Predictive analytics work when they are used. All right, so this is kind of what ours looks like. These are evidence-based. You can go find them in your articles. I promise they're there. You know, that's what my paper was on. It was great. But you score them. So if your heart rate is this, you have this score. And we add it all up and we color code it. If you're 0 to 1, you're green. If you're 2 to 4, you're yellow. If you're 5 or greater, you're red, and nobody likes red. Red's bad, very bad. We put those together, but just one predictive analytics score for sepsis doesn't work. How many of you all think there's one score that tells you, oh, hey, I'm septic? Doesn't exist. Does not exist. We wish it did. SIRS kind of gets us there, and the Muse score kind of gets us there, but they don't really get us there. We have to combine them together. What we really want to do is we want to give you a predictive analytic tool that narrows it so you have less false positives, that it's really telling you, hey, there's probably something going on. Use your different predictive analytic scores that you have available to you within your EHRs or that you have wanted to push with your IT team. We've included in ours shock index. Shock index, let me go back, is the heart rate divided by your systolic blood pressure. And it's been shown in the evidence that if your score is 0.7 or greater, you are at increased risk for sepsis. Does it mean that you're septic? No. Does it mean that you could be? Yes. And that means our index of suspicion is up, and now we're going to start down we're going to assess you for sepsis path. Same thing, you'll notice that some of the stuff for Muse and some of the stuff for SIRS are the same, but they're looking at it and they're grading it a little bit differently, which is why we want to use the two tools together to help us reduce that false positive.